Thank you for joining us today for our video, Meeting the Psychosocial and Physical Well-Being Needs of Immuno-Oncology Survivors. Today, I am joined by some expert panelists. First, we have Dr. Thomas Smith, Harry J. Duffy, Family Professor of Palliative Medicine and Professor of Oncology at Johns Hopkins Sidney Kimmel Comprehensive Cancer Center. Next, we have Dr. Neha Goyal, Psychologist, Cancer Services at UCSF Helen Diller Comprehensive Cancer Center, and Dr. Dawn Dizon, Director of Women's Cancers at Lifespan Cancer Institute and Director of Medical Oncology at Rhode Island Hospital. Thank you for joining us today. So we want to start today in really clarifying the discussion around defining survivorship in immuno-oncology treatment. We first want to acknowledge that survivorship can be a very loaded word for patients, and a lot of patients don't really love the word, and it can mean a lot of different things to different people. So we want to reaffirm the broad definition put out by the NCCS as survivor and why it is important that we're just talking about any person diagnosed with cancer from the time of initial diagnosis until their death, or living with, through, and beyond cancer. So I'd like to get started by asking, what are some of the psychosocial and physical needs that are important to people being currently treated with or treated by immunotherapy in the past?
So I'd say one of the, there's so many existential issues that come up for these patients who are living with what may or may not be considered a terminal disease. And so there are questions that come up very frequently, like, should I retire? Should I, what should I do about family planning? Should I have kids? Should I take that big trip that I wanted to take? And so these are really questions about a changing sense of self. How do I now identify as a patient, as a person, as a whole, who has this diagnosis of cancer? And I think that's one of the things that really comes up a lot when we're talking with patients.
Other things I see are fatigue and uncertainty and burnout. Fatigue and tiredness, often from the treatment. Often people get demoralized because they're just sick and tired of being sick and tired. Maybe not be depressed and there's not a pill for it, but demoralization is a real thing. And it's really important to recognize it and give people some skills to get out of that hole. And the other thing is the uncertainty. I mean, growing up as an oncologist, most cancer chemotherapy for lung cancer, for instance, 50% of people will have died at a year or more. And now it's only 25%. I think as a breast oncologist, as a medical oncologist, and as a palliative care person, if you're thinking about immunotherapy, it's a really good chance to think about living well, about an advanced medical directive, about some advanced care planning. The other words of advice I can give, being a metastatic cancer survivor myself, is have these discussions at 2 o'clock on a Wednesday afternoon, not at 3 a.m. in the emergency department where you're being met by people you've never met before and they have no idea who you are and they're searching around in the medical record to find your advanced care planning. It's just so much easier to have these discussions by the light of day. And it doesn't have to be one discussion. It's typically a whole bunch of them. So things evolve over time. They may be very different when you're just starting therapy, and it may be very different when you have this inflection point of the cancer progressing. But have those discussions and write it down. Believe me, your healthcare providers will really, really thank you.
And I think even as, providers, or that this definition of what is survivorship is often evolving. So oncologists tell me that patients are often asking, how long will I be on treatment? Will I ever get off? When will I get off? And those pieces of uncertainty, as Tom mentioned, are really, I think, difficult sometimes for patients to really sort of wrap their head around. And oftentimes, while patients have some side effects, sometimes they're doing well. And so it's hard, again, for them to reconcile, okay, so outwardly I look healthy, but I have to keep going in for these treatments, or, I still need help, even though my social support has started to fall off as time has progressed.
And, I think those kinds of issues are so relevant in other aspects. So, for example, You know, I used to just see the person with cancer when I talked about sexual health. And then I realized, it does take two people to have a relationship. And with that came this idea, you actually need to speak with both. And what was really striking is that people who are living with metastatic disease, and it's all sorts of tumor types, the relationship changes. And if you don't take that into account, you're not going to help them move forward. The person with cancer with brain metastases may really want that intimacy of a sexual encounter, but her partner has been a caregiver. He's been in the hospital with her. Perhaps that person was the one who was holding her hair up when she had hair while she was throwing up, giving her shots at night. And there's a mental adjustment where you're no longer the romantic partner, you are the caregiver. And that is such a sensitive topic to try to work through. But you can help them work through that. It's just not a conversation anyone has ever thought they were going to have.
So I'd love to hear next, why is it important that we talk about survivorship for those on immuno-oncology treatments in relation to psychosocial well-being and care?
For such a long time, and I think it was unintentional, but survivorship has been associated or was synonymous with people who are treated for cure. We talked about, the life after cancer, and we talked about the importance that you don't die of heart disease, and we talked about, how to have kids and, the ways to get pregnant. Now we have this new population of folks who are doing well, but they're also on treatment. And we don't know how long they're going to do well, and we don't know when they're going to stop therapy. And, unfortunately, I think oncology and palliative care and survivorship are all separate silos, and getting those needs met in a comprehensive place across the country is still not available. So there is this sort of schism, and I think, Dr. Smith and Dr. Goyle are part of that efforts to try to get rid of this schism, to say, you might have metastatic disease, but you're doing well. We need to talk about physical activity. We do, if you want to talk about diet, we're here to help you with that. We want to talk about intimacy, let's do that as well. But, the talks and the difficult conversations and the talks of goals and preferences that really belie palliative care oftentimes will just force people into a system or a segment of care. And then there's no way for them to navigate to the other side of things. So that's why it's important. We need to talk about survivorship beyond just preparing for the unknown, but how to live today and the best way you can.
I can emphasize what Dr. Dizon said. It's really important to think not just about the cured patient, but people who are living day to day with metastatic disease, but still have psychosocial needs, caregiver needs, sexual needs, bone health needs. Should I be taking an aspirin every day? Should I get my cholesterol checked? All those things. So those are all the concerns, plus the increasingly complex area of genetics for most cancers. And should I have my DNA banked? Should I have a blood sample stored someplace? Because I couldn't find anything on my BRCA1 and BRCA2 testing, but I know there's something in my family. That sort of issue comes up all the time. You add to that the cumulative toxicities of therapy after therapy after therapy. So you've got peripheral neuropathy and a fall risk from chemotherapy 5 years ago. And then you've got a constant fatigue state, rash, and maybe hypothyroidism from the immunotherapy, as well as potential to develop more serious therapy-related issues. You might have a little bit of nagging pneumonitis from the immunotherapy, but you're still being a normal person, or as normal as you can be, adapting to whatever your new normal is. So we just have to ask the person sometimes, well, what are the issues that are affecting you the most?
And I think, again, with survivorship, patients are considering other, options for improving quality of life. So now patients want more information about diet or exercise or psychosocial health and stress management. And so I think we have to be considerate of that, right? Knowing that patients are looking for how to improve their quality of life, not just from a curative standpoint, but from a how do I live well with this disease standpoint.
You know, you find that people who are living with metastatic disease, their doctors only want to talk about therapy and the next steps. And there's a whole bunch of other stuff in the background that we don't even know about. But we can't ignore that, especially since we are actually changing, you know, the goalposts. And like Dr. Smith said, people are living a longer time.
Well, I'd love to hear from the panel. What are some ways that we can better support these survivors and their family members?
Well, I think one of the ways is to make use of your team. You know, most centers now are not, you know, in practice by themselves. And if they are part of usually a network of other people who can support patients. If you have social workers in your building, they should be meeting with your patients, you know, at transition points is how I like to say it, when they're first diagnosed, but especially when they're hearing that the disease is back, and especially when you're changing therapy. These are really, really tough transition points, and having someone check in with them that's not the one giving them the medical news is oftentimes really important. You know, early referrals into psychology is really critical. And then I am a big believer, and I think Dr. Smith will talk about this, about engaging on palliative care early. All of my patients who are on immunotherapy are offered a palliative care referral the moment I've diagnosed them with metastatic disease. And I think it's really important. And it might be 4 years later and they're getting married. They have not, none of them have said, I don't need to see palliative care anymore. They just become a part of that team. But as important, I think Dr. Goyal and I spoke about this a little bit, you know, not assume that this is the only aspect of someone's life that needs to be taken care of. You know, offer them the support and offer them the, you know, validation that if they're interested in changing their diet or stopping smoking or seeing somebody for help about intimacy, or, you know, or getting family therapy, these are entirely relevant for the duration of whatever life you have. We need to help you live it.
As Dr. Dizon mentioned, it's really important to get palliative care involved early. That the last 3 weeks or 2 months of life is way too late to change any trajectory and get people to planning. The other part about palliative care is really make sure that your palliative care team is doing sort of the best practices model. I go back to Jennifer Temmel's lung cancer study in the New England Journal from 2010. And there's a chart there about what was actually in those visits. We start with her second category, which was symptom management, because symptom management's always safe. You can talk about pain, you can talk about pulmonary symptoms, you can talk about mood, depression, anxiety. Those are always safe things. And you can then build up a trust relationship to go on to some of the more difficult ones. But in her study, that first visit took 55 minutes. I don't know very many oncologists who have 55 minutes to give to every patient every month in their busy practice. It has to be somebody else. I think as oncologists, we're sometimes afraid to bring up these issues. Maybe they haven't thought about dying before. Maybe they haven't thought about what's going to happen to their spouse or their family, or leaving behind $100,000 a bill. As a cancer patient, I can tell you there's nothing you can bring up as a healthcare professional that hasn't kept me awake at 2 o'clock in the morning. Absolutely nothing, whether it's sexuality, impact on my family, impact on the family finances, impact on my caregivers. There's nothing you can bring up that I haven't already spent too much time thinking about. So don't be afraid to bring up these difficult issues. Just bring them to the forefront so you can make a list of them and try to help with some of them.
And I'd add to always make sure to kind of check in with the family members and the caregivers. So I think often we think about how can we best support the patient, which is really important. But at the same time, you know, cancer is not something that just affects the patient. It affects the entire system, the entire family system. And so making sure that you have a list of resources for the caregivers, because in my experience, when as a team, we support the caregiver, the patient also feels supported because they know the ones that they love are being taken care of. And so in many ways, it's important to make sure we're embracing the entire family and folding them into the care.
So we talked about some impactful actions and great resources. I'm wondering if the panel could talk about how programs can meet survivors' psychosocial and physical well-being needs when they have limited resources.
One of the biggest resources we have is us. Everybody has the ability to ask questions. So just remember to ask, how are you coping? And turn to the family and ask, well, how are you coping? And what is your understanding of your situation? Simple, easy things. And what are your main concerns? Just make a list of them. The other thing I found very helpful is having a structured goals of care discussion that I can bring up on Epic, just like I'm showing somebody their x-rays, and make sure I cover all the important points so that it's not like trying to explain adjuvant chemotherapy different every time. It's a structured discussion that lets me make sure I cover the difficult issues. If I can't get through it all in one visit, I can say, well, let's print out what we did today and let's make sure we cover it next time. And I'm happy to share those. Hopefully we can put them up on the website.
I think one of the biggest resources people can take back to their center is just to understand what we were saying about who should be considered in this discussion about survivorship issues. And it's not to pigeon all of these folks who might be living with metastatic disease into the palliative care arena and all your cured patients into the survivorship arena. If you have survivorship services, recognize that there's a group of people on immunotherapy who are as interested in that as anybody else would be. The whole point of what we're trying to do is help people live while we're helping them survive with medical therapy. And that means we need to make accessible any of the services you have already in place, but widen the doors so that more people can access that. I think if there's any take-home point, don't reinvent the wheel, just make the car run smoother.
And I'd add that even if there's not direct resources, there's a plethora of online communities, online resources that are available to patients nowadays. And so really creating a list of those resources and not just handing them to the patient as like an afterthought. I mean, of course, there's not a lot of time to talk about it, but even if you hand it to them and normalize the experience of seeking those supportive care services, that's very impactful when it comes from a medical provider. So you hand that paper to them and say, many patients find talking to other patients or a professional is really helpful during this time of increased uncertainty and anxiety. So here's a list we've curated, and I'd highly recommend that you check it out. And a friendly reminder that even these providers are not just one thing. So as a psychologist, I don't just treat depression and anxiety. I can help with pain, fatigue, sleep. And so making sure you're utilizing the resources that you have well.
Well, I want to thank our panelists so much, specifically Dr. Smith, Dr. Dizon, and Dr. Goyal, so much for your both personal and professional expertise. I think we feel very inspired to go forth. Please be sure to visit accc-cancer.org/immunotherapy to stay up to date on the latest tools and resources around survivorship care for patients who've received immunotherapy. We have a publication called Survivorship Care Plans for Patients Receiving Immunotherapy. And we have special episodes on the Cancer Buzz podcast, like Survivorship Care After Immunotherapy. And we have additional resources like the ACCC IO wallet card. Thank you so much.